Thank you very much. I wanted to thank Dr. Ronco for including me in this panel and for the invitation. It's a real honor and privilege to be included among the experts and the thought leaders in the field of acute kidney injury and CRRT. I have no conflict of interest, no disclosures, just to let you know that I'm a clinician with interest in ICU nephrology and an educator. Some training in research, but I don't do active clinical research at this point. So what I'm going to present to you is the data and interactions with our critical care colleagues and how we deal with this big question. So I'll start with the case. I created a very simple case of a 65-year-old man with a history of stage 3 chronic kidney disease, type 2 diabetes, hypertension, and dyslipidemia, who's admitted to the hospital with severe abdominal pain. He's in the emergency department with a blood pressure of 96/55. He is febrile, tachypnic and tachycardic, has abdominal tenderness. His labs show elevated creatinine, elevated lactate, white count, and a potassium of 5.1. His urine output has dropped, and within the past 3 hours of being in the emergency room, he has only made 40 milliliters of urine. So he quickly gets, with the diagnosis of sepsis, gets broad-spectrum antibiotics and receives initial 2.5 liters of intravenous crystalloids. He's transferred into the to the ICU, is started on norepinephrine, and now he remains hypotensive. Should we give more fluids? And if we so, what do we track it with? How do we monitor this patient? So first question is, what is the goal of volume expansion and fluid resuscitation in the ICU? And the answer is to improve tissue perfusion and oxygenation. How do we monitor that? And if you ask many different intensivists or experts in the audience, they probably do a different way. And also, if you go look at the research studies and in the critical care and nephrology literature, what is the definition that has been used to show that a person is fluid responsive or not? So we'll talk about that. So in septic shock, the ultimate goal is to increase tissue perfusion, increase urine output, normalize lactate, but these, as you know, are not very sensitive markers of improvement. In the literature, for the studies, the gold standard that has been followed is to look at cardiac output. If a patient, in response to fluid and volume challenge, increases their cardiac output by 10 or 15%, they were marked as fluid responders. If you look at the blood pressure, it's not a good indicator because it's not only dependent on the cardiac output, it also depends on the vascular resistance, and a rise in stroke volume may not necessarily translate into an increase in blood pressure. Pulse pressure, on the other hand, is probably more dependent on stroke volume and cardiac output, but pulse pressure, an absolute value, also cannot be a perfect method. And as most of you in the audience know, changes in CVP and end-diastolic volume may reflect change in preload, but they do not provide any information or may not be able to predict the changes in cardiac output. All of you familiar with this graph of Frank-Starling curve, and what we learned in physiology that our cardiac output is dependent on the preload. This is a normal heart. So if you increase the preload from point A to point B, then you increase the cardiac output. But it depends on the status of the heart. If you have cardiac dysfunction, you may not be here, and the graft is shifted down, and increasing preload does not help you much and may not increase your cardiac output. So if you look at the most recent guidelines published late last year and early this year, patients with sepsis-induced hypoperfusion, the guidelines suggest that they should be initially treated with 30 milliliters per kilogram of body weight of intravenous crystalloids within the first 3 hours of presenting to the emergency department, the data on this is not that great. And then this is the initial step, which should be followed by careful monitoring. And as you know, initially the studies on early goal-directed therapy suggested following certain parameters like the central venous oxygenation and also CVP, which are no longer supported by newer data. It could be because they're already achieved those goals. So the guidelines suggest you do your initial fluid resuscitation, and then that should be followed by hemodynamic assessment to see if further fluid management is needed. And to achieve that, since we know CVP and pulmonary artery opening pressures, the absolute values do not perform well, the suggestions is to move to more dynamic measurements as opposed to static numbers and numbers that deal only with preload at one point of time. And once the fluid challenge is initiated, then we have to very carefully see the need for further fluid challenge and also the safety of further fluid challenge, because as you know, many studies have suggested that fluid overload can be associated with increased mortality. So what do? We need to check heart rate, blood pressure, arterial oxygen saturation, respiratory rate, temperature, and urine output. Echocardiography is a very helpful tool, but again, I'm not going to go over into the details. Many of the experts in the audience can help us, but that's another hour lecture. What do you focus on when you do echocardiography? But it's becoming more and more popular in the intensive care units. The intensivists are doing bedside echocardiograms, and as we mentioned, we should not base our decisions based on solely on a CVP or pulmonary artery pressure value, especially when they fall within the normal range. The performance of these numbers are very marginal and poor. So what are the dynamic measures of fluid responsiveness? So basically the idea is if you talk about the mechanically ventilated patients, during the inspiration and when the air is forced into the thoracic cavity, that positive pressure results in reduction of venous return and as a result cardiac output. So if you look at the variability of stroke volume during the respiratory cycle for somebody who is on a ventilator, completely sedated without any spontaneous breaths, if the venous return, the central veins are volume depleted and empty, that change in the respiratory cycle is much bigger than somebody who is well volume resuscitated. So these parameters that can be followed are, one is pulse pressure variability, the other one is stroke volume variability. They require an arterial line and a special monitor. You can also monitor the aortic flow variations by echocardiogram and Doppler. And also you can look at the diameter of vena cava during this cycle and look at the IVC collapsibility, or percentage of change in the diameter of IVC. Looking at the stroke volume variability and pulse pressure variability, many studies came out early on. All of them are in patients who are mechanically ventilated, completely sedated, no spontaneous breath, with high total volumes. And they showed that these two tests, pulse pressure variability or stroke volume variability, if the number is greater than 10 to 13%, depending on the study that you look at, they performed very well. The problem is that if the patient creates a spontaneous breath, or if there are arrhythmias, and if the tidal volume is smaller, not at the level of 10, like let's say at 6, these tests do not perform very well. Next one, as I mentioned, is IVC collapsibility. This is a study of 23 septic patients on the ventilator. Again, these are patients on the ventilator, sedated with no spontaneous breath. And again, as I mentioned, the definition of a fluid responder was an increase in cardiac index by about 15%. So they did at baseline, and then they gave patients a dose of 7 milliliters per kilogram of body weight fluid, and they looked at the IVC collapsibility post. So if you can read the slide here, here is the delta IVC percentage change, and if you can see the patients who were responders, basically after fluid treatment, the patients who increased their cardiac index had a very high change, and after receiving fluid, that dropped. And the patients who did not respond to fluid was a lower number, and so that way they were able to separate the two groups. This is one of the studies. So in that study, 18% change in IVC diameter in the respiratory cycle performed actually quite well. The problem is that it was not replicated in many other studies. Here's another example. In this study, again, 44 patients in the ICU with sepsis on ventilator. Again, pre and post volume expansion. This time, the definition of fluid responsiveness was exactly the same. And most of these studies, about 50 to 60% of patients were fluid responders. If you look at the number here, they looked at the delta superior vena cava diameter and inferior vena cava, and you see a big difference compared to the previous study, 38% sensitivity, 61% sensitivity for the IVC collapsibility, and here they were able to show SVC was superior to IVC. The next question was, can this be used if the patient is taking spontaneous breath? As you can imagine, here, instead of creating positive pressure in the chest cavity, when you take in the spontaneous breath, like a normal physiology, you're creating a negative pressure. But basics are the same. So you're looking at the delta IVC diameter. Here, they looked at patients with spontaneous breathing. Again, fluid responders was defined by increasing in subaortic velocity time index by transthoracic echocardiogram. Again, half of patients were responders. One of the things, for those of you in the audience who review these papers and editors of journals, I think this is a great thing to have. Instead of just looking at the area under the curve and looking at the populations, these studies are small enough for us to be able to put points on the graph, because when you look at the populations, you may get a good p-value separating the two groups, but in reality is that when you check it for your patient, you just get one dot. What do you do with that? So one thing here they say, for patients who do have spontaneous breaths, the number is closer to 40%, and in some other studies are going even higher to 50%. Meaning if the change in the IVC diameter during the respiratory cycle is greater than 40 or 50%, the patient is probably going to respond to fluid, meaning they're going to increase the cardiac output. So as you see here, the responders, majority of them had higher level, but some of them had lower levels. This person had no change. And if you look at it, the non-responders, most of them had small changes. On average, people who had more changes responded better. And this is the area under the receptor operator curve with a value of 0.77. So their conclusion was that in spontaneously breathing patients, and they looked at the aortic flows, it's simple, but they said you should interpret it with caution. A high value of greater than 40% is usually associated with fluid responsiveness. The next test is passive leg raising. Basically, the way it has been described and performed, it varies a little bit. So basically, you can put your patient with their head and body up at 30 to 40%, and then you put them flat. Next thing you do, you raise the leg. and the gravity helps you, and that would be equivalent of giving 300 to 500 ml of fluid to the patient just by returning the fluid from the legs. And then this increase in the preload can be, you can look at it and use it instead of giving patients real fluid. So this is a meta-analysis of 9 papers, 353 critically ill patients in shock. On average, again, half of them with fluid responsive. And in these studies, so again, you raise the leg, you increase the venous return. The question is now, what do we measure? In some of these studies, they looked at pulse pressure variability. In some of these studies, focused mainly on cardiac output with different methods. Some of them, they looked at flow velocity, time indexes, and some of them looked at the stroke volume. So the thresholds for cardiac output methods that they set was about 12 to 15%, similar to the pulse pressure variability, and they got much better sensitivity, specificity, and the pooled area under the curve with the cardiac output measures as opposed to pulse pressure variability measures. In this study, they used esophageal Doppler, and they measured the descending aortic blood flow after PLR, and they set a threshold of 8%, and they got a sensitivity of 90%, specificity of 50% in prediction of response to fluid. So again, if you look at the plot of responders versus non-responders, it looks much better than what we just looked at. So again, they set a threshold of, let's say, 8% here. And if you go a little bit higher, maybe a little bit above 10%, you will have a very good specificity for this test, and probably is going to perform well based on this data. Again, here you see the performance of passive leg raising. If you look at the aortic blood flows, if you look at the pulse pressure variability, and compared to the more non-dynamic tests. Then in the prospective study of 71 mechanically ventilated patients, here they set the threshold for 10%. Again, they use esophageal Doppler, and they also they give them to test if this works or not. They use the patients, they gave the patients 500 ml of saline in 10 minutes. And here it had a sensitivity and specificity of 97 and 94%. And if you look at the pulse pressure variability, greater than 20% had lower, less good of a performance compared to monitoring blood flows. The sensitivity and specificity for pulse pressure was 88% and 93% without spontaneous breathing and no arrhythmia. So again, if you look at the plot of the data, here you're seeing the PLR-induced changes in aortic blood flow, again around 10% in this study. You see a good separation of the two groups, not as well if you monitor the pulse pressure variability. And here's the graph for AUC. So similar to that, because as we just talked about, you have to do echocardiograms and check the time, velocity time indexes, or place an esophageal Doppler to measure the velocities in descending aorta. How about checking the carotid artery velocities? In this study, 40 patients. These are not septic patients. So again, you have to be careful who your patient population is, and when you're trying to generalize these patients. These are patients who are undergoing cardiac bypass surgery, and they've measured the variation in carotid artery peak velocities during the respiratory cycle, and they put a cutoff value for 13% for pulse pressure variability and about 11% in the delta peak carotid artery velocities. And you see here, again, the flow velocities, if you go with the carotid artery, perform better than if you look at the pulse pressure variability with the AUC of about 0.85. Here's the details of the data. So if you look at here, responders, at baseline, they had 13% change, which went down to 6%. Non-responders had 8% and 8%. At baseline, there was a difference, and after volume expansion, they still showed a difference. With other parameters, they didn't perform well. Even in non-responders, there were differences, and this clearly shows that performed better. So in summary of this part, I have a few other slides. So pulse pressure and stroke volume variations, about 13 to 15%, perform well with very specific conditions. Patient has to be on the ventilator, sedated, no spontaneous breath, with high tidal volumes. IVC collapsibility index may be helpful. There are some issues with familiarity with the technique and inter-observer variations, but the numbers look like you have to go with numbers much higher, especially in spontaneous breathing patients of 40 to 50%. And passive leg raising is a simple test. The question comes, what do you follow after that? Maybe velocities and not pulse pressure variation. The advantage of this is that the patient could be spontaneous breathing or on the ventilator. Things that, like arrhythmia, that makes you not be able to use pulse pressure variability and stroke volume variability do not alter the results of PLR. But if the patient has high abdominal pressure, or if you have a CHF patient with a low EF, you have to be careful, and you may not be able to use this technique. But all we talked about was these techniques that predict who's going to increase the cardiac output. But that's not what we want to get to. We want to see how, if we can come up with a way to predict who's going to benefit and have better tissue perfusion. And we still don't have an ideal tool. And if you, in my conversations with different colleagues, most of experts that I have talked to do a combination of things, bedside ultrasound being a major component. So there are other things that have been discussed, one of them being the gap between mixed venous and arterial CO2 as a measure of tissue perfusion. And in this study, when they looked at cardiac index at baseline, these are patients, 50 patients with septic shock. They got their initial fluid resuscitation, and they have central venous oxygenation greater than 70%, all of them do. But they divided them into two groups, one with a gap of less than 6 and the other one greater than 6. I apologize, this is greater than 6. And then the cardiac index at baseline was much higher in this group. They cleared lactate much better in the next 12 hours, and their SOFA score dropped significantly better. So septic patients with high gap may require further resuscitation, while these patients with the lower gap were doing better. So also, if you look at the new guidelines, they suggest monitoring microcirculation. Because we know that in septic shock, there is this decreased capillary density, decrease in the percent of perfused capillaries, and also integrity of the microcirculation is changed. And if you look at the survivors of sepsis and non-survivors, you see there is a difference in their microcirculation. One of the techniques that has been used is the orthogonal polarization spectral imaging, or OPS, which is a small camera with lenses used as a non-invasive way to visualize the microcirculation at bedside. And this is one of the pictures from that publication that shows a healthy volunteer with intact microcirculation as opposed to a patient in septic shock. So maybe this can be used for direct visualization of microcirculation, because that would be the ultimate goal. So in this study, 18 patients on mechanical ventilation with early septic shock, they had a MAP of less than 65 to be included in this study. They were on vasopressors and evidence of an infection to prove that they're septic shock. They put microelectrodes for CO2 sensors under the tongue to measure tissue partial pressure of carbon dioxide. And they calculated the gap of sublingual CO2 by subtracting arterial and sublingual CO2. And at the same time, they used the OPS imaging to look at the microcirculation. And then the data was collected before and after giving them dopamine. Dopamine increased heart rate, increased the cardiac index, and SVO2, and reduced lactate in this study. So if you look at this graph, it shows baseline and after dobutamine. And we're looking at the gap in the PCO2 that almost all of the subjects dropped the gap in CO2 after receiving dobutamine. And there was a very tight correlation with the R-square of 0.73 looking at delta lactate and delta CO2. Here is the graph of that gap versus perfusion of the capillary by OSP technique. And again, you're looking at the gap, dopamine, and after effect of dopamine on that. So in one study of septic patients on early goal-directed therapy, subjects with an improvement of at least 2 points in their SOFA score 24 hours after treatment had significantly higher improvement in their microcirculation, as 88% compared to 47% improvement in microcirculation in patients who did not improve clinically. And as I mentioned, currently the guidelines say this should be investigated further and is only recommended as a research tool until more data is available. So in summary, in recent years, there have been changes in management of critically ill patients with septic shock. Recent guidelines do not advocate for static measures, especially one measurement of CVP, and they do not recommend setting CVP or SVO2 targets for early goal-directed therapies. To decide about fluid management, the decision should be based on multiple factors, including dynamic parameters, which maybe need to be used in conjunction, and maybe monitoring tissue perfusion, metabolism, and oxygen consumption with newer tools in the future would provide better ways to manage our patients with septic shock in the intensive care unit. Thank you for your attention.